Good morning, people. What do we got? 5 people. Jesus. Puppy dog. Whoa, that's worse. Puppy dog. Can you put your faces on? I think we're going to be looking at each other today. Hey, Matt. Bezowit. There's Bezowit. Bezowit, are you still in Africa? Africa?
No, I came back to classwork.
Oh, okay. I'm sorry. That's my sister.
Hi.
She's the cardiac nurse. I'm trying to talk her into doing a presentation for us next week, but I don't think I'm getting very far with it. All right, so looks like it's just us. There's a lot more people than this in the class. I don't know why nobody's showing up. But anyway, let's start out talking about that the quiz I put up for you last weekend. So I'm going to share it. I'm going to be asking you to answer the questions because I don't know the answers to these. You know I'm lying. Okay, so here is, I think this is whole animal cardiovascular responses to norepinephrine, epinephrine, and isoproterenol. So the key thing here is alpha versus beta, right? Alpha receptors versus beta receptors. So, and there's a lot of stuff here we didn't really talk about yet. We're going to get to it eventually, but hopefully working through this, you'll understand it better when we start talking about it. So anyway, how do you account for the difference in peripheral resistance between norepinephrine and epinephrine? This is key. Mike. So we're looking at peripheral resistance, which is the bottom. So peripheral resistance is like contraction of the arteries. With norepinephrine, we get a real big increase in peripheral resistance. With epinephrine, it goes down. Why is that, Mike West? You're muted.
Is that just how betas work? Is that how they typically they have the downward curve instead of the upward?
Downward curve instead of the upward. We're talking about contraction or relaxation of smooth muscle of our artery. So why is it with?
No.
Is that your dad? Is that your dad? Yeah. Tell him not to shoot, okay? Sorry, bad joke. So we're looking at alpha versus beta with norepinephrine versus epinephrine. So I believe I talked about this last. Anybody have the answer here? Ariana? No. So I think I talked about this, or I wrote it in the notes last time or something in our last lecture. So all vascular smooth muscle has alpha receptors. Alpha receptors activate IP3 calcium, cause contraction. That makes peripheral resistance go up. The vessels leading to skeletal muscle, though, have alpha and beta. So if you've got an agonist that's more beta than alpha, you're going to see the beta response. And the beta response is cyclic AMP and relaxation. So when you look at norepinephrine peripheral resistance, all you're doing is activating alpha receptors, really, mostly. Boom, resistance goes way up. With beta, you're activating those alpha receptors on like the vessels that go to your skin, your intestines, all these other things, but to the skeletal muscle, you're relaxing them. And you've got a lot of blood supply to the skeletal muscles. So the overall response is a decrease in peripheral resistance. Okay, does that make sense? Because this is important to getting the whole rest of this figure. Okay, so to answer your question, how do you account for the difference in peripheral resistance between norepinephrine and epinephrine? Epinephrine is more beta, and the beta receptors on the vessels that lead to skeletal muscle relax. So overall, even when you add up the fact that it's going up in other vessels, it's going down so much in these vessels, you get an overall decrease in resistance. Okay, why does diastolic pressure go up with norepinephrine and down with epinephrine? Diastolic pressure. Okay, so that's this one here. You can see the diastolic pressure goes up with norepinephrine and then down with epinephrine. And it really leads off what we said in the last question. What do you think?
I said alpha receptors cause increase in the systolic pressure. Beta receptors cause an increase in the systolic pressure when they're in the heart, and then when they're leading it to the skeletal muscles, they cause relaxation, which shows decrease in the diastolic pressure. And when we come to the alpha receptors, they have the same effects in all vessels, so we see an increase, a contraction, which causes an increase in the diastolic pressure. So that causes the difference.
Right. So it really leads off here because your alpha receptors are increasing resistance. Because resistance goes up, you get an increased pressure. And here, because resistance goes down, you get a decrease in pressure. Yep, it's your alpha versus beta again. Third question is, and this is something, I'll give you a hint if nobody gets it, but why does the heart rate go down with norepinephrine and up with epinephrine? So what receptors are in the heart first, Ariana? What receptors, alpha or beta?
Alpha? I know it's beta blockers. Yeah.
Okay, right. Okay, beta receptors. So in terms of heart rate, norepinephrine's going down, epinephrine's going up. Why is epinephrine going up? With the beta receptors, what do? Beta agonist.
Isn't it causing vasodilation?
Heart though, we're talking about the heart right now. You don't remember? You guys. Okay, beta receptors are in the heart. They're in the SA node. Does that mean anything to you? SA node?
I think that has something to do with the baroreceptors.
Yes, exactly. And some we haven't talked about, but you're right. Okay, so we have only beta receptors in the heart, right? So if you look at isoproterenol, boom, heart rate goes up. Epinephrine also goes up. Okay, why is norepinephrine going down? Because you figure it does activate beta receptors, so heart rate should go up. Why does it go down? Benzoate? Is it benzoate or benzoate?
Benzoate.
Benzoate, okay. Benzoate. So why does it go down? What did you say?
I think it has something to do with the activation of the baroreceptors.
Right. Can you tell us about that a little bit? What activates the baroreceptors?
The beta receptors.
No, they're like the response. What's turning on the baroreceptor that then tells it to respond?
Not sure about that.
Baro. What does baro stand for? Barometer. Barometer.
Isn't it pressure?
Pressure. Right.
Oh,
So-
blood pressure.
So you're right, but you're missing the details here. So allow me to go. So if you look at norepinephrine, pressure goes up, right? Pressure goes up, activates the baroreceptor. You get a reflex back to the brain, which comes down through the vagus nerve, decreasing heart rate. So that's why your heart rate is going down there because of that baroreceptor reflex. Let's see what else we got here. Pulse pressure. Ooh. I was going to ask somebody what it was, but I have it written there. Okay. Pulse pressure is the difference between systolic and diastolic pressure. Why is pulse pressure greatest for isoproterenol? Ooh, that's a good question, which I don't think you're going to know the answer to. So pulse pressure is the difference between this and this. And this is greater than the norepinephrine one, and the beta one is even greater, the one that's all beta. So what's the big difference with beta receptor, like only beta versus alpha and beta. If you're comparing epinephrine, isoproterenol. Celine.
Do you mind repeating what you said? It's hard to hear you with, I think you're making coffee.
Yeah. Oh, my sister's making coffee over here. So, okay, pulse pressure, difference between systolic and diastolic. Why is it greatest here for isoproterenol compared to the other two? And kind of give you a little hint, what's the difference between just beta versus beta plus alpha?
Because then it has like a higher affinity for just beta instead of it competing with the alpha.
Right, it has only beta. Isoproterenol is only beta, but why would that give you a larger pulse pressure here?
Because it's only binding to beta receptors.
Right, exactly. But what are the beta receptors doing when you activate all beta receptors? Why are you getting a larger pulse pressure than when you activate alpha as well?
Because there's a greater constriction.
Constriction with what? With alpha or beta?
Beta. Or alpha.
All right. I don't know if I gave you guys enough background to understand this thing, but we're working through it together, and I think that's a good thing. So, and this question especially, I don't think you have a way to understand it until we have some more hemodynamics. So, but anyway, when we get into hemodynamics on Tuesday, we'll talk about preload and afterload. Preload is how much the how much stretch you get in that ventricle when it fills, and afterload is how much pressure the ventricle has to push against. So this is an afterload problem. Afterload is what is your diastolic blood pressure. What's the pressure you have to beat to get that blood out of the ventricle, right? The mitral valve opening. So here with epinephrine, you've decreased peripheral resistance, but with isoproterenol, you've really decreased peripheral resistance, right? Because this is activating alpha on the vessels that only have alpha receptors. You're activating those alphas, but the skeletal muscle ones are giving you an overall down. Here you have only those skeletal muscle vessels, and they're opening up, pressure is going down, so your heart has less pressure to push against when it's pushing. And so you get a much larger pulse pressure. Okay, that makes sense? Let me say it again in a different way. So if you remember our cardiac cycle where it was like, where it's like the vessel fills. Let me see myself here for a second. The ventricle fills and the pressure goes up slightly, then it starts to contract, and you get this isovolumic contraction until the mitral valve opens, and then the heart squirts all the blood out, right? So that point there, if it's lower, you're going to get more blood out. If there's a lower diastolic pressure, that mitral valve opens sooner, and you get more blood out of the heart, and so that's your pulse pressure is going to be greater. I don't know. We'll come back to this next week after we do hemodynamics. So I feel like I've lost you all at this point. Anyone lost besides me? No? Okay, just me. Why does diastolic pressure increase for norepinephrine but decrease for epinephrine? It's like the same question over and over again. So did I ask that already? What was my first question? How do you account for the difference in peripheral resistance? Why does oh, look at this, I asked it twice. Why is diastolic pressure increase for norepinephrine, decrease for epinephrine? Yeah, I asked it twice. Okay, so let's not answer it again. All right, so again, let me just go over this figure again to see if we can make sense out of it. Norepinephrine is more alpha than beta. So when you hit with norepinephrine, both diastolic and systolic pressures go up because you're contracting your peripheral vasculature. And so you've got a lot more resistance that you're pushing against, so the pressure gets higher. Epinephrine is more beta. Oh, and also with norepinephrine here, because your pressure increases so much, you can, right in the middle of the diastolic and systolic is the mean pressure. So the mean pressure goes up. And for that reason, your baroreceptors kick in and you get a decrease in heart rate. Over here, your mean pressure is probably going down a little bit, if anything, right? What would be in the middle of those two lines? So with epinephrine, you're activating beta receptors directly, so you're increasing heart rate, but also you're not getting that baroreceptor response that would decrease heart rate because you're not changing your mean arterial pressure very much. And again, with your peripheral resistance, preferably beta over alpha is going to get you a decrease in peripheral resistance because you're relaxing the large veins going to your skeletal muscle and contracting the other ones, but there's less blood going there anyway. And then isoproterenol, only beta. Of course, heart rate goes way up because you're just activating beta receptors on the heart. And mean arterial pressure goes down. So you're not getting that. You might even get a compensatory norepinephrine being released on those beta receptors because the pressure goes down so much. And that diastolic pressure is so low because your peripheral resistance is really, really low. Just activating the beta receptors on the vessels going to skeletal muscle. Okay, was that confusing enough? How many people think they got some of that anyway? A little bit? Nobody? Just me? It's okay. As long as I do well on the test, the hell with you guys. When is our next test? Is it next week? I hope not. Let me check the syllabus real quick. Of course, we can change it. Oh, there's Matt Camellan. So my syllabus says October 13th, which would be next Tuesday. Next Tuesday. I guess that's okay. Can we have a test next Tuesday? This is yes. We good with this? Test next Tuesday? No one's that excited about a test next Tuesday. Well, the next thing I want to talk about is hemodynamics, which is kind of a big topic, and we may need a couple lectures to get through it, which would be putting the test off for a whole nother week. So why don't we go ahead and have that test Tuesday, and it'll be on everything we've covered since the last exam. So a lot of intracellular mechanisms and such. Okay. Okay. This is yes. This is no. Yes. Okay. All right. So let's look at this paper. I'm not sure. I've done this paper in the past. I looked over it this morning. It was a little different from what I remember it. But let's go ahead and get started with this paper. Hopefully you've all at least taken a run at reading it. It is somewhat complicated. So we're talking about the ryanodine receptor. Oh, and here's an important thing. New word, calstabin. Did you see calstabin in there? Say yes, Dr. Slish. Yes, Dr. Slish, we saw it because we read the whole paper. So calstabin is the same as FKBP 12.6. So that's the actual name of I guess it's a new name for FKBP 12.6. So a lot of what this paper is about is that interaction between calstabin and the ryanodine receptor. And something new they're adding on top here is the oxidation state of the ryanodine receptor, which I never heard of that before. I mean, I know things can be oxidized, but I didn't know the ryanodine receptor was. So something new for everybody here. All right, Ariana, why don't you start reading the introduction, the first paragraph, and I'll interrupt you when I think you need to be annoyed by me.
Heart failure A syndrome, characterized by progressive deterioration of cardiac function, represents a major public health burden and is a leading cause of morbidity and mortality in the Western world.
Okay, can I I'm sorry, let me interrupt for a second. So we're going to talk about heart failure in a few weeks in the next section. But what heart failure is the heart doesn't contract as strong as it's supposed to. And so the end diastolic volume keeps increasing and increasing, and you get this enlarged heart, and it's not contracting strong anymore. So that's what heart failure is. Sorry, go ahead.
With more than 5 million affected Americans, heart failure treatment includes administration of beta-adrenic receptor blockers with improved cardiac function and reduced mortality. We have previously reported that beta blocker therapies inhibit pKa hyperphosphorylation and remodeling of iodine 2 receptor channels, complex in humans and animals with heart failure. While treatment with beta blockers represents a major therapeutic strategy for heart failure patients, the precise mechanistic basis of action of these drugs in heart failure downstream of beta-AR blockade remains poorly understood.
Okay, so hang on one second, sorry. So if you think about it, the heart's not beating strong enough. So what do you want to do? Give it a beta agonist and make it beat stronger, right? What they're saying is, no, you do better if you block the beta receptors. Why is that? That's kind of paradoxical. You know, you would expect cardiac function to decrease if you couldn't activate beta receptors, but here it's increasing. Can't wait to find out why. Go ahead.
During cardiac excitation, contraction coupling, and action potential triggers a small amount of calcium to enter the myocyte through the L-type calcium channel. This event triggers a much larger intracellular calcium release by activating the ryanodine receptor calcium release channel on the sarcoplasmic reticulum, a phenomenon referred to as calcium-induced calcium release. Calcium release from the sarcoplasmic reticulum into the cytosol binds to troponin C, causing a conformational change that enables an actin-myosin cross-bridge to occur, resulting in shortening of the sarcomere and cardiac contraction. Calcium reuptake into the SR via the calcium ATPase and removal from the cell, mainly by the NACA exchanger, lowers calcium, resulting in dissociation of calcium from troponin C and cardiac relaxation. Disruption of this highly coordinated process can trigger arrhythmias, and defects in calcium cycling are associated with HF progression.
Okay, good. So that was kind of a review of what we talked about with cardiac contraction before. Why don't we have Celine read the next paragraph, at least?
Heart failure is categorized by a sustained hydro or hyperadrogenic state in which serum catecholamine levels are chronically elevated. We have shown that one consequence of this chronic hyperadrogenic.
What's catecholamines? Anybody know what a catecholamine is? A dogacholamine? I don't know. Catecholamine? Nobody knows? Adrenergic, catecholamine. So whenever you hear catecholamine, that means either norepinephrine or epinephrine. So in chronic heart failure, you've got elevated levels of norepinephrine and epinephrine. Go ahead.
State is persistent with pKa hyperphosphorylation of ryanodine 2, such that 3-4 out of the 4 serine 2808 in each tetrameric ryanodine channel are chronically phosphorylated. We have shown that chronic pKa
Let's take that sentence apart. We have shown that one consequence of this chronic hyperadrenergic state is persistent pKa hyperphosphorylation of the ryanodine receptor. So pKa is phosphorylating the ryanodine receptor. Hyperphosphorylation means an awful lot of phosphorylation, such that 3 to 4 of the serine 2808 in each homotetrameric ryanodine. Homotetrameric, what does that mean? Homotetrameric, homo, same, tetra,
4
meric, units, right? So you've got 4, the ryanodine receptor is 4 identical units that come together. So that's your homotetrameric. And serine 2808, you know, in one of those units, the 2808th residue is a serine, and that's a phosphorylation site, okay? So they're saying that 3 out of the 4, you've got 4 tetramers, at least 3 of the 4 of them are phosphorylated. We have shown that one consequence of this chronic hyperadrenergic state is persistent pKa hyperphosphorylation of the ranitidine receptor, such that 3 to 4 of the serine 2808s in each homotetrameric ranitidine receptor are chronically phosphorylated. So that's what they mean by hyperphosphorylation. You've got 4 units and they're all phosphorylated mostly. All right. Go ahead. Stop after each sentence, because I think these, papers like this are so dense. Everything's so dense. And if you just keep reading, you miss most of what's going on there. So go ahead, Celine.
Okay. We have shown that chronic pKa hyperphosphorylation of ryamidine is associated with depletion of the channel stabilization subunit calstabin from the ryamidine channel macromolecular complex.
Right. Macromolecular complex. Do you know what that means in this? Well, we'll find out later. Everything that's involved. Macromolecular means you've got a lot of different proteins together. So it's a big complex. And we'll see later some of the other proteins involved. And calstabin, remember, is that FKBP 12.6. All right, go ahead.
This results in a diastolic SR calcium leak that depletes the SR of calcium, contributing to impaired contractility, and is associated with fatal cardiac arrhythmias due to activation of inward depolarizing currents.
Right. Diastolic leak. Mike, tell me about your diastolic leak.
It's crazy.
I like Mike already.
My sister likes you already. His hair is too long, though. He needs a haircut. So, what am I going to do? All right, so diastolic leak, what does that mean, and what do you think, why is that important? One of the questions on the last exam was about this, kind of. I think this is where I got it in my head that this would be important. How about Matt Gamelin? You've been quiet today.
What was the question?
That's always the first question. What was the question? Diastolic leak. Where is it? Diastolic SR calcium leak, depleting the SR of calcium. What is the question? What does that mean to you? So what's going? Let me just. All right. What the hell are you getting at? Basically, during diastole, that ryamidine receptor should be closed, right? That only opens at the beginning of systole. And during diastole, there's still calcium coming out, right? Which is going to decrease the amount of calcium in your SR, so you can't contract as strong, and also keep a little bit of way too much calcium in there during the relaxation period. So if you remember the last question on the last exam, I was talking about that. If you've got elevated diastolic calcium, and then you can't contract as high because of it. Okay. Where the hell am I now? Okay. And this cardiac arrhythmias, yeah, it's just calcium activated channels. We're not going to worry about that. All right. Indeed. Celine, indeed.
Indeed, mice.
Wait. You have to do this when you say indeed. Indeed. No? Okay. Go ahead.
Indeed, mice. Thank you. Engineered with ryamidine liking the pKa phosphorylation site are protected from HF progression after Mario. Can you stop moving the bag?
Sorry.
Please. Sorry. Where were we?
Indeed. Mike, we're right here.
Thanks. Indeed, mice and engineered with ryamidine lacking the pKa phosphorylation site are protected from HF progression after myocardial infarction.
So how would you engineer a mouse to have a ryamidine receptor that lacked a phosphorylation site? Here's an interesting experimental thing. How would you do that? You know about transgenic mice? Yes? No? This is yes. This is no. No, nobody knows about, yes, Matt knows.
Are they
Bezoit.
using like CRISPR?
Exactly. That would be a great way to do it. I don't know if they're, I don't know if that was what they used here, but yes, that would be a way to do it. Two women just won the Nobel Prize for that too. Pretty cool. So you go in, you take out the normal gene that's there, put a new gene in, and this one lacks that serine that gets phosphorylated, so it can't be phosphorylated anymore. So mice engineered with ryanodine receptor lacking the PKA phosphorylation site are protected from heart failure progression after myocardial infarction. Okay, Celine. Furthermore, give me a finger. Furthermore. No? Okay.
Where is furthermore?
Right here.
Furthermore, we have shown that the chronic PKA hyperphosphorylation of ryanodine in HF is associated with remodeling of the ryanodine macromolecule complex that includes depletion of phosphatases PP1 and PP2A and the cyclic AMP specific type 4 phosphodiesterase from the ryanodine complex.
So that's what they're meaning by the macromolecular complex. It's not just the channel, it's the channel plus calstabin, plus PP1, PP2, and phosphodiesterase are all in this one big macromolecular complex. And we'll see how they all change with time over here. All right, go ahead.
Depletion of PDE4D3 from the ryanodine complex causes sustained elevation of local cyclic AMP levels.
All right, go ahead.
This is our general agreement with the key finding of our studies, which is that diastolic SR calcium leaks contribute to HF progression and arrhythmias.
Okay, keep going.
However,
Go ahead.
However, several specific aspects of our model are controversial, including the role of ryanodine PKA hyperphosphorylation and calstabin depletion in HF. These findings have both been confirmed and challenged in the literature.
Okay, so we're going to be watching phosphorylation of this particular serine and how that changes the makeup of this macromolecular complex. All right. Almost there. Almost get to look at data. Okay, Mike, why don't you go ahead and start reading over here at given complexity.
Given the complexity of PKA signaling in the heart, it's difficult to examine the effects of chronic PKA hyperphosphorylation of ryanodine 2 in the absence of effects on other calcium handling proteins. In order to overcome these difficulties, we generated a knock-in mouse model with that mimics constitutive PKA hyperphosphorylation of ryanodine, in which the serine in ryanodine was substituted with an aspartic acid residue. In contrast to our earlier results, using recombinant human ryanodine, ryanodine serine, right? What's that saying?
It's a ryanodine receptor with serine to aspartate.
2809.
Yeah. What are we going to call this to get around it? Let's just call that the ryanodine receptor mutant. The active.
Okay.
Start over again with in contrast to our earlier studies.
In contrast to our earlier studies using recombinant human mutant ryanodine receptor channels, ryanodine channels from young, those are non-mutant, right? With the 2808.
That's the mutant one.
Okay. Okay.
The mutation.
The 9 is the normal one?
Usually if they don't have, like up above, they don't have a D here, it's just S2808. When you have a D, that means you replace the S with the D. Let's talk about that for a second. Why does that mimic hyperphosphorylation? What's aspartate look like?
Isn't it really polar?
Yep. What charge is on it?
Positive?
The other
Oh,
one,
negative?
negative, right? So imagine this. Serine is just got an OH, right? pKa comes over, puts a phosphate there. You've got a big negative charge. So what they've done here is replace that that serine with an aspartate. So there's already a negative charge there. So it's mimicking just constantly being phosphorylated. You could also replace it with an alanine. So you just take the OH off, and then it couldn't be phosphorylated. So you can do both mutations and simulate phosphorylation or unphosphorylatable. So, Mike, why don't you start with in contrast again?
In contrast to our earlier studies using recombinant human mutant ryanodine receptors, receptor channels, ryanodine receptors from the young mutant ryanodine receptor mice were able to bind to calstabin and displayed normal single-channel activity. However, older mutant ryanodine receptors mice exhibited decreased calstabin binding and calstabin 2 binding to ryanodine receptors and decreased cardiac function, which correlated with dysfunctional mutant ryanodine receptor channels examined in planar lipid barriers and increased diastolic SR calcium leak in ventricular myocytes.
Okay, so remember when we were talking about beta agonist stimulation of the ventricular cells, I said, which turns out not to be true, that you phosphorylated calstabin and that makes it come off the ryanodine receptor, and then you get more calcium release from the ryanodine receptor. Turns out it's actually phosphorylating the ryanodine receptor, but that makes calstabin come off, and then you get more calcium out. And you're also going to get calcium leak in a chronic situation. So what they're saying here is, even when it's hyperphosphorylated in young mice, right, less than 3 months, calstabin still stays connected to it. And then the same thing later in life, it comes off, and then now the SR is leaky. So in class, we said it's phosphorylation of the receptor that causes it to open up like that. But here we're finding out it's more than just that. There's something else going on because there's an age-related change in the function there. Even though you know it's always phosphorylated, it's not a phosphorylation-dependent event. Does that make sense? Am I going too fast, or is that good? You guys got to nod your head or shake your head or tell me what's going on. Does that make sense? Yes? Yes? Okay. All right. So, however, Mikey, or did we do that? We did not. Oh, we did that already. Okay. So we're down here with these effects.
These effects were associated with progressive oxidation and nitrosylation of ryanodine receptors in mutant ryanodine mouse, suggesting that chronic pKa hyperphosphorylation combined with oxidation, okay, I didn't skip a line, and nitrosylation substantially disrupts channel activity in vivo. Furthermore, beta blockers improve cardiac function in WT mice after MI, but failed to improve cardiac function in mutant ryanodine receptor mice after MI, suggesting that inhibition of pKa phosphorylation of ryanodine at serine 2808 is a critical mechanism by which beta blockers improve cardiac function in heart failure.
Okay. So getting back to my initial question, why is it beta blockers help function? It's because it's blocking production of cyclic AMP and hyperphosphorylation of the ryanodine receptor. Okay, well, this is hard. This is a struggle. We haven't heard from Matt Gamelin nearly enough today. Let's have Matt Gamelin start reading this. And again, stop after every sentence because, you know, it's so dense. I don't want to just read through it and not understand any of it.
Starting at results.
Yeah.
Generation of the mutant receptor knock-in mouse model. The genotypes of ES cells and knock-in mice were confirmed using both Southern blotting and PCR. Methods. Mutant receptor mice were viable and fertile and were born at the expected Mendelian frequencies.
Okay. So knock in ES is embryonic stem cells. So they took embryonic stem cells, they knocked out the normal ryanodine receptor, put a new one in, and then they made mice out of them. And that's just, telling you that, yes, it worked. It's good. We are good. So this mutant plus plus means these cells have got two genes in both genes. I mean, these mice have got two of the mutant genes. So the only ryanodine receptor subunits there are from this gene. All right, Matt, go ahead.
Mimicking chronic PKA phosphorylation of a receptor causes age-dependent cardiomyopathy. Homozygous mutant and wild-type littermates were examined using echocardiography and cardiac catheterization from 1 to 12 months of age to determine the consequences of chronic PKA phosphorylation of receptor on cardiac function.
Okay, go ahead.
Serial echocardiographic measurements over the course of a year revealed that receptor plus mice exhibited progressive age-dependent cardiac dysfunction.
Okay, go on more, and then we'll look at the data.
Cardiac dysfunction was manifested as a reduction in the ejection fraction coupled with a slight increase in LV diameter.
Okay, what's LV stand for? LV? What organ are we looking at?
Left ventricle?
Left ventricle, okay. Left ventricle. And ejection fraction, that's something we haven't talked about. What's ejection fraction, do you think? Considering we're looking at the heart. Ejection fraction, no one wants to guess? Bezowit? Usually make good guesses. See, Bezowit's problem is she knows more than she thinks she does.
I don't know. Actually, I don't know what ejection fraction is.
About the heart. Think about the heart. The heart's ejecting blood, right? So what ejection fraction is then diastolic volume. Let's see. And then you've got systolic volume. So ejection fraction would be, what's the difference between systolic and diastolic compared to the diastolic? So how much of the blood in the heart comes out for each contraction? Ejection fraction, okay?
So that's the pulse difference over the diastolic pressure?
No, it's the end diastolic volume minus the end systolic volume gives you the ejection amount, and divide that by the diastolic volume.
Okay.
Your ejection fraction. And that's going to tell you how strong the heart is contracting. If the heart is weak, ejection fraction gets small. If it's strong, ejection fraction is big. So it's a really good measure for congestive heart failure.
Okay.
So let's look up here at figure 1A. So figure 1A is ejection fraction. And here you can see over time. Here's the normal mouse, and here's the mutant mouse. So this is what they're talking about. Oh, your ejection fraction with these hyperphosphorylated ryanodine receptors is going down over time to the point where you're down here, now you're in heart failure, and you're going to die. Okay, Matt, I want you to guess this because I know you can. LVEDD. What's LV?
Left ventricular.
Okay. ED. We just talked about it. End diastolic.
And diastolic.
Diameter. Okay. You know, in this hemodynamic stuff, it's all going to be acronyms like this. So you need to get used to guessing what it is properly. So LV is always left ventricular, end diastolic, diameter. So what is the diameter of the ventricle, left ventricle, during diastole over time? So what do you see here, and would that be concerning to you? Celine. Oh, Celine's not here. Celine had to step out momentarily. There's hardly anybody here. I've got no one to pick on except Ariana Totarum. What are you seeing here, and what does that tell you?
Well, it seems like the left ventricle is like enlarging. So maybe that's going to lead to like heart displacement.
Exactly. That's what congestive heart failure is. Like I was saying earlier, if it can't contract strong enough to eject all that blood, it starts to grow, and that's heart failure. And the last one, Ariana, what's LVESD?
Left ventricular systolic diameter.
Right. So the size of the ventricle at the end of systole. And what do you see there?
It seems like it's enlarging as well.
Okay. So what we've shown here is what they've shown here is what they said before, which is that when you substitute in this hyperphosphorylated ryanodine receptor, in young mice, it's okay, right? Young mice down here, it's the same as control, but after a year, you get big differences between control and whatever. So it's not just the hyperphosphorylation, there's something age-related that's going on that's also causing a problem. All right. So let's just do ejection fraction and skip the other ones. What are we seeing here with ejection fraction? Black is control, white is the test. Mike, just reading the chart, the graph, what's happening with ejection fraction over time?
It's far lower with the normal and with the mutant. The ejection fraction is really weak as far as that, and then
Right.
the normal one, it goes down over time. I guess this decreases with age like it normally would.
Yeah. Well, another thing tied on top of this, though, that I guess I should have told you before I asked you to read it, was isoproterenol. So they're chronically treating with isoproterenol. We just talked about isoproterenol. What kind of agonist is that?
Beta.
Beta agonist. What happens when you chronically stimulate beta receptors to the beta
Lose
receptor?
sensitivity, right?
Desensitivity, right? So they're desensitizing. So they're comparing. Oh shit! Go away, you. They're comparing desensitized normal versus your mutants, and so here your ejection fraction is really low. I don't know. I'm getting lost myself on this one. I'm doing all the work here, damn it. You're getting paid too. All right, let's just go over. Let's read on. Maybe they'll explain it to us. Let's hope so. So where were we? Who was reading? I think Matt was reading.
Maybe.
Where's Matt? Start reading serial echocardiographic measurements.
Serial echocardiographic measurements over the course of a year revealed that the receptor plus mice exhibited progressive age-dependent cardiac dysfunction. Cardiac dysfunction was manifested as a reduction in the ejection fraction coupled with a slight increase in LV diameter. Similarly, cardiac catheterization at 1, 2, 6, and 12 months of age revealed a progressive deterioration of cardiac contractility in receptor plus mice that was not evident in wild-type littermates. This reduction in cardiac function was comparable to the effects of chronic isoproterenol treatment of 4-month-old wild-type mice compared with that of age-matched receptor plus mice. At 4 months of age, there was already a significant reduction in ejection fraction in the receptor plus mice. Chronic ISO treatment did not cause a further reduction in ejection fraction, whereas it reduced EF in the wild-type mice, such that after 4 weeks of ISO treatment, the ejection fraction of the wild-type mice was reduced from approximately 80% to a level comparable with that of the receptor plus mice.
Okay. So, why do you think I'm hearing an echo? I'm hearing like a scary echo. Can you hear that? Okay, must be the devil. So, why would chronic ISO treatment be used to compare against this mutant? Why are they doing that? for a buck. I will pay anyone a buck. I'll give anyone an A in this class just for figuring this out. You know I'm lying when I say that, but I'm saying it anyway. What does activation of beta receptor do? Let's start there. Does it what? Activation of beta receptor causes what? Second messenger?
Relaxation.
No, we're talking about the heart. The heart.
Contraction and increase in blood pressure.
No, let's just look at one ventricular cell. What does activating beta receptors do? Increases what second messenger? You got it.
Cyclic AMP.
Cyclic AMP, right? Which activates protein kinase A. And what does that do in ventricular cells? So I believe this was early in this test material we talked about this. So it's kind of important that you know this. So because then it doesn't make sense unless you understand the background here. So if you activate those beta receptors, you turn on protein kinase A, and that phosphorylates the ryanodine receptor. So why are they comparing that to this mutant? Because this mutant is mimicking a hyperphosphorylated receptor. Okay, does that make sense?
Yeah.
Okay, so they're going to take a 4-month-old normal mouse and chronically overstimulate the beta receptors to hyperphosphorylate that channel in the wild type, and that brings the function. Let's see. That brings the function way down. Ejection fraction is small, should be over 80, but it's way down because you've overstimulated those receptors and you're getting that calcium leak from the ER. And with the mutant, oh, this is the wild type coming down to the mutant. Sorry, I've been screwing that up. Chronic hyperphosphorylation brings down ejection fraction. And here, the mutant already has a low ejection fraction because it's already hyperphosphorylated. I guess that's what they're trying to show. This is hard. I need you guys to step up a little bit here because I'm not sure you're getting anything out of this. Okay. However, Matt, go ahead and read from however again. However,
chronic ISO infusion did cause comparable increases in LV and systolic diameter in the wild type and S208D mice. These results are consistent with our findings in the companion manuscript, in which cardiac function in the receptor mutant mice was similarly protected from the deleterious effects of chronic ISO. However, chronic ISO infusion did result in an increase in LVESD.
okay. So, Bezuit, why don't you read the next paragraph?
Mutated receptor plus mice also exhibited increased heart weight to body weight ratios compared with those of the wild type controls. Historical studies of the receptor plus hearts at 2, 6, and 12 months of age confirmed the results of echocardiography showing the hearts from the receptor plus mice exhibited mild enlargement at 12 months of age. Should I go on?
Yeah, go ahead.
No increased fibrosis was detected using Mason's trichrome staining compared with wild-type litter meats. In addition, apoptosis assessed by tunnel staining showed no differences between wild-type and the receptor plus mice at any age examined.
Okay, so the hearts seem pretty normal except they're enlarged.
Yeah.
All right, Bezuit, keep going with the next part because now we're going to look at the oxidation state of the receptor and how that affects the macromolecular complex. Go ahead.
Age-dependent oxidation and nitrosylation of the ryanodine receptor in the mutated ryanodine mice. We have reported that the ryanodine macromolecular complex undergoes remodeling during HF, characterized by depletion of calastevin, PDE4D PP3 and the phosphatases PP1 and PP2A from the ryanodine molecular complex in order to determine whether the age-dependent reduction in cardiac function observed in the ryanodine plus mice was associated with the ryanodine complex remodeling. Components of ryanodine macromolecular complex, including PP1 and PP2A, PDE4D3, and colastabin were examined using the co-immunoprecipitation with an alpha ryanodine antibody.
Two things here. One, I really like the way you pronounced calstabin. I like it better your way, colastabin. That's really cool. But it's supposed to be calstabin. But let's do it your way because I like your way better. The other thing is co-immunoprecipitation. What is that? This is important. This is something you'll see in a lot of papers, co-immunoprecipitation. What do you think it means? What does immunoprecipitation mean? Is Celine here? Celine, immunoprecipitation.
Co means together, doesn't it?
All means together, or what do you mean?
Like immuno has to do with like, I don't know, you're asking the wrong person.
No, you're getting there. Immuno is what? When you think
So
of
like antibodies, things like that, like in your immune system.
right. So immunoprecipitation.
And then precipitant, isn't it like a solid form?
Right. So if you've got the protein in solution and you hit it with this antibody, it'll precipitate and you can isolate that protein. Okay, so it's a way of, if you've got a protein like this that's very low in cardiac cells, you can take a whole heart, grind it up, immunoprecipitate, and pull out just your protein. Okay, that's immunoprecipitation. So what would co-immunoprecipitation be, do you think? Because we're looking at macromolecular complex here. What do you think?
That a very large group of molecules came together?
Right. Exactly. So they're going to have an antibody against a ryanodine receptor. They precipitate the ryanodine receptor, and they see what other proteins came down with it. All right. So they're not specifically grabbing the other proteins. They're just going to see what got carried along with the ryanodine receptor. And that's going to tell you about the state of the macromolecular complex at different ages, different disease states. Okay? Because we're looking at remodeling, which means you've got 4 proteins here that should be coming along with the ryanodine receptor. How does that change over time? Okay, Matt, who's reading now? Jesuit.
There were significant decreases in the levels of PDE4/3, PP1, PP2A, and calstabin-2 in the ryanodine complex by 6 to 12 months of age, consistent with the development of cardiac dysfunction and comparable with the remodeling of the ryanodine complex, though we have shown occurs in failing hearts. The levels of ryanodine and calstabin-2 in cardiomyocytes were not changed with age in the wild type or the ryanodine plus mice, and the time points examined.
Okay, so let's look up at that figure. Let's ignore these sections for a minute. So here's your immunoprecipitation wild type at 1.5 months and at 12 months. There's your ryanodine receptor. Does this change at all in wild type? No. This doesn't change. This doesn't change. This doesn't change. Okay. So no change over time with the wild type. And the function doesn't change either, so that makes sense. Okay. So now we look at our mutant, age 1.5 to 12 months. What happens with PDE? This compared to this.
Diminishes.
Right, it drops off. PP2 also drops off. PP1 drops off, and calstabin drops off. So this is what they mean when they say remodeling, okay? Because you're changing that macromolecular complex by having some of these proteins come off of it. Okay. So go ahead, Dr. Lemma.
There was a progressive age-dependent depletion of calstevin-2 from the ryanodine complex with minimal calstevin-2 depletion in a 6-week-old ryanodine plus mice, and near complete depletion of calstevin-2 from the ryanodine complex in 12-month-old ryanodine plus mice. The progressive age-dependent depletion of calstevin-2 from the ryanodine plus complex cannot be explained by progressive pKa hyperphosphorylation of the channel, since the pKa site serine is not available to be. Can you scroll up, please?
Yes.
To be phosphorylated in the ryanodine plus channels.
Okay. So you're seeing this breakup of the complex, but it's not because of phosphorylation, because this thing has been phosphorylated since it was made, or phosphorylated anyway. All right, go ahead.
We therefore examine the oxidation of ryanodine-2, since we have recently observed that oxidation of ryanodine enhances pKa phosphorylation-induced depletion of calstevin-2 from the ryanodine complex. Furthermore, oxidizing agents have been shown to promote ryanodine-mediated saccharolemma calcium leak, and ryanodine-2 was reported to be oxidized in failing hearts from the canine model of HF.
Go ahead, keep going.
We also examined cis-nitrosylation of ryanodine receptors, since cis-nitrosylation has been reported to cause depletion of calstevin-1 from the ryanodine complex in skeletal muscles. And we have recently shown that cis-nitrosylation of ryanodine-1 and ryanodine-2 in skeletal and cardiac muscles from a mouse model of
Duchenne.
muscular dystrophy causes depletion of calstevin-1 and calstevin-2 from ryanodine-1 and ryanodine-2 respectively.
So you're saying it wrong. Colostabin. That's how we're.
Okay.
No, I'm teasing you. So let's take a quick look at that. Where is it? Up here. So here, these two things are showing you the increase in oxidation of the channel, which is correlated here with the breakup of that macromolecular complex. Okay, so that's what they're talking about. Okay, where were we? Duchenne. Wait. Celine wouldn't do this, but I need you to do it. When you say indeed, you put one finger up. Indeed.
Indeed. There were age-dependent increases in both cis-nitrosylation and oxidation of cardiac ryanodine-2 from the mutated ryanodine mice that likely contribute to the age-dependent depletion of calstevin-2 from the ryanodine complex in the mutated ryanodine mice.
Okay, so what they're showing then is that there is a like it's not just the phosphorylation, but it's the phosphorylation coupled with oxidation that causes calstevin to come off. Okay, I don't think we're going to get into this figure because this is electrophysiology, which I get, but it would be hard to explain. All right, let's hear Celine read again. To determine
whether increased cis-nitrosylation and oxidation of ryanodine occur in failing hearts, we examined ryanodine from 3 patients with end-stage heart failure and from mice with post-MI heart failure. Ryanodine was nitrosylated and oxidated in both human and murine failing hearts.
Okay, so that lines up with their experimental evidence. Okay.
We next assessed the effects of treating cardiac microcell fractions with hydrogen peroxide. Hydrogen peroxide resulted in oxidation of ryanodine and a reduction in the amount of calcium in the ryanodine complex in cardiac. Did you do something?
No.
Oh.
No.
I thought you were doing like the timeout sign.
Oh, no, I'm sorry. No.
No, you're good.
I was just, yeah.
And a reduction in the amount of calcium in the ryanodine complex in cardiac microsomes with wild-type mice by approximately 20%. In contrast, oxidation of rhyamidine wild type by 1 millimolar hydrogen peroxide caused nearly complete depletion of psilocybin from the rhyamidine complex in cardiac microsomes from 1.5 months old rhyamidine wild type mice.
Okay, figure 3A and B. Let's take a quick look at that. It's figure 3. It's figure 4. Figure 2. Okay. Oh, yes, I remember this one. Okay, so here, oh shit, sorry. Sorry, potty mouth. Okay, so here, what they're doing is they immunoprecipitate, and then I believe anyway, in vitro, they're they're oxidizing the channel, and that's causing, here's your oxidation state going up. As the oxidation state goes up, the calstabin interaction goes down. Okay. And here's the one I like. All right, we're almost done. So let's have someone besides me, because I'm getting tired. I'm old, you know. I'm getting tired. What does this figure mean to you? Here's control. So this is normal, right? And this is calstabin bound to the ryanodine receptor. Okay, S35. So they've labeled it with radioactivity. So this is the normal amount of calstabin on the ryanodine receptor. What happens with pKa phosphorylation?
It decreases.
Okay. What happens with oxidation?
It decreases, but not as much as pKa.
Okay. Probably as much, because you look at those error bars, it's probably, you know, and there's no star over it. What happens if you do both?
It depletes it a lot.
Right, right. And you can see by that star that it is significant. And now here, pKa with S107. I don't know what S107 is. I think it's where you take the phosphorylation sites out, but I'm not sure. I'd have to look that one up. Okay. Okay, and then this is just talking about the oxidation ratio, the oxidation rate. So you can see oxidation goes up in these mutant ones. All right, so maybe we should finish there. So I guess what I want you guys to get out of this is the whole idea that, you know, in heart failure, you've got a leaky SR, and it's because of calstabin coming off the ryanodine receptor. And why is it coming off the ryanodine receptor? Hyperphosphorylation is part of it, but oxidation is another part of it. You know, they always talk about oxidation getting worse as you get older. It's a progressive thing, oxidation damage. So that seems to be important too in this heart failure model. So that's about all we're going to do on this paper. I think that's enough. We've got it. That's my sister, my dopey sister.
Back to 5 again, page 5.
My dopey sister is going to give you a talk on cardiac ICU.
Ain't happening. I haven't worked in 19 years. I forgot everything I knew.
So anyway, so I will get a practice quiz up online in Moodle for you. Hopefully today. You can look at it over the weekend. If you have any questions, you can email me, and then Tuesday will be our exam. Okay.
The moral of the story is leave and go to Penn State. We are Penn State.
Penn State. Never mind. Stay at Plattsburgh. We need your money. All right. That's all we're doing. Do you have a question?
Yeah. Are we gonna get a practice exam or this exam?
Yeah. That's what I was just saying. Today I'm going to get one up there for you. You can look at that. I guess I should put the answers in too. Yeah, I'll do that. I'll put the exam and then like on another page below, so you don't cheat. I'll have the answers to the questions. Okay. It'll just be 4 questions because it's just going to be the harder questions, not the memorization questions, but the more difficult ones. Okay. Everybody good? I'm gonna let you go. 3, 2, 1. See you next time, guys.